Hi, everyone. I'm going to be talking today about the era of telemedicine for the ambulatory setting. My name is Veronica Rivera. I am an ambulatory geriatrician. I work here at Mount Sinai at the Martha Stewart Center for Living Uptown, where I'm also the medical director and I see older adults in the outpatient setting. I also have the opportunity to see patients at a federally qualified health center in East Harlem here in New York City called the Institute for Family Health. So I do have experience seeing patients in these two different settings. And so today we're going to be talking about telemedicine and hopefully providing you with some important information and resources moving forward as you're using telemedicine in the ambulatory setting. I have no financial disclosures, but I did want to also take the opportunity to thank the following individuals: Doctors Vanessa Rodriguez and Julia Friedman, who helped with prior versions of this talk, and also members of the American Geriatric Society, the Telehealth Subcommittee, who also helped create some of this material. So for objectives, by the end of this presentation, I hope that you'll be able to define the terminology of telehealth and telemedicine, explain some of the benefits of telemedicine, explain the barriers of telemedicine, help assess which patients are most appropriate for telemedicine services, integrate the appropriate steps to conduct prior to, during, and after a telemedicine visit, and document all the necessary items that should be incorporated in a telemedicine visit, and then ultimately select the appropriate billing codes for your visit. So starting off more broadly, just talking about the terminology of what is telehealth. So the definition is the use of electronic information and telecommunication technologies to extend care when persons and clinicians are not in the same place. So there are different ways to have telehealth between patients and clinicians when we are not in the same place. And a couple of the different types are: one, asynchronous, where you may be secure messaging your patient. This, for example, might be on an online portal within your electronic medical record. Two is synchronous, for example, via live video messaging or video visits with a patient, so at the same time. And then lastly, remote person monitoring. So this is an example where you might have home glucose monitoring or home blood pressure monitoring that allows care between patients and clinicians. And so again, telehealth is this sort of broader category terminology that we use technology to support a broad range of healthcare services. And this can happen on smartphones, online, and this helps, again, clinical care be delivered between patients and providers. And then when clinicians actually provide care to patients on an audio or audio-visual platform, this is part of telehealth, is called telemedicine. And so that's predominantly what I'm going to be focusing on today when we are doing video visits or audio-only visits with our patients in the ambulatory setting. So a little bit of context before we get into some of the details. We have seen a large increase in the use of telehealth, of course, since the COVID-19 pandemic. And so you can see prior to 2020, about less than 20% of our physicians were offering telehealth to patients. And then quickly we had to have a big uptick in use of telehealth because of the pandemic. And you could see here data from June of 2020, where primary care visits among Medicare beneficiaries went up to 50-50, 50% happening in telehealth and 50% in person. So a quick uptick as a result of the pandemic. And this schematic also just shows the increase and sort of the timeline that we've seen over the last few years. Again, early of March of 2020 was when the public health emergency was officially initiated and the pandemic started. And there was the CARES Act and CMS waiver, which basically put into place relaxed regulations and allowed more easier reimbursement for our telehealth services that we were offering to patients. And these were, in many instances, temporary waivers that really allowed reimbursement for video and audio visits to allow that patients have access to their clinicians for both routine and emergency care. And then fast forward to May of 2023, there was officially an end to the public health emergency. But subsequently in 2023, there was a Consolidated Appropriations Act passed by Congress that allowed a continued expansion of some of these telehealth policies through December 31st of 2024. So at the time of this recording, we are approaching the end of these expansion of some of these policies, and so it's still to be determined the status of some of these policies. And this is a little bit of a busy slide, but just wanted to show a little bit more context of some of the changes that happened because of the pandemic and these expansions. So for example, initially, only certain clinicians were allowed to do telehealth, and now any type of clinician, including physical therapists, occupational therapists, audiology, for example, are allowed to do telehealth. There is no requirement to have a pre-existing relationship with a patient. In terms of location, they can happen at any location, including a patient's home. Prior, certain areas were specified or required, for example, in designated rural areas. And then physicians are now able to conduct from any location through these expansions versus just being in their place of practice. But one of the expansions that did end was state-specific restrictions. So we still are unable to cross state lines, again, in terms of providing telehealth. And then audio only is still included in the expansion at this time, but it will be to be determined on what will happen after December of 2024. And one of the expansions that did end was allowing other platforms like FaceTime, Zoom, or Skype. And then in terms of reimbursement, we are still able to bill Medicare for these telehealth services. And there is providers can waive the cost sharing covered by federal programs. But the reimbursement is for telehealth is still the same as it is for in-person visits. And then these expansions again are subject to end December of 2024. And we'll go into the billing a little bit more later. In terms of benefits of telemedicine and telehealth, absolutely we've seen a lot of satisfaction because of the convenience and comfort that patients and providers are able to have when doing telehealth. So we have increased access to care to patients who live in rural areas or have difficulty coming into visits in person. And so, for example, even in concentrated cities like New York, we do have patients who become homebound due to their functional impairment and environmental constraints that ultimately telemedicine and telehealth have allowed us to have increased access to these patients. We have seen improved health outcomes because of telemedicine, management of chronic conditions like diabetes and hypertension. There's some evidence that things have telemedicine has a huge impact in those areas. Ability to access more efficient care to patients who are already established, increase access to specialists, even prompt access to acute care services, and potentially reducing emergency room visits. For example, community paramedicine has been one of those examples that we've used telemedicine to help acutely triage patients, come up with care plans to help avoid the emergency room and keep them in the community. Obviously, because of the pandemic, we're well aware that reducing in-person visits for those who are acutely positive with COVID-19 or under an examination, that has also helped reduce spread and help protect the health of other patients in our practices. And then there has a big impact on patient satisfaction and both caregiver satisfaction and well-being as well. On the flip side, there are some barriers to telemedicine. One huge issue is access to technology. So patients to do telemedicine need access to the hardware and adequate internet access to be able to participate in these visits with providers. We are also encountering that some patients have limited digital literacy, and that definitely limits their ability to complete a video visit. Of course, with our older adults, we're seeing physical and cognitive impairments that are also impacting their ability to participate. There is also a potential risk for depersonalization of the patient-physician relationship. So some of our seniors do really love that in-person interaction and touch that you sometimes lose with a video visit or audio-only visit. Another barrier to execution of telemedicine is a lack of caregiver support, so that we do have a high-risk population that often needs more monitoring and support and help with connecting on video visits. So lack of caregivers can be a real barrier. There are also some reimbursement and regulatory challenges, which we'll reference later. There's a potential risk for security and privacy violations. And then there's also risk for using telemedicine in the setting of inappropriate prescribing. And so medications that need more close monitoring observation, this might be a higher risk. A little bit more about the digital divide. Again, because of the digital divide that we are seeing in our communities, this can, for many of our populations, unfortunately limit access to telehealth. So again, thinking about opportunities within your community and in your via your public services, thinking about how to improve access to the actual equipment needed to access technology, the ability to use that technology, so connecting patients to education or resources where they might be helping seniors learn how to use this technology, and then helping seniors also obtain broadband or internet coverage. Those are things that we really should be doing to help improve this digital divide. And so, for example, a little bit of data, this was from the Pew Research Center. You could see here this percentage of US adults who say they do not use the internet. And the largest group, as you can see here, is the over 65 age bracket. So that again is the population that we are often working with. And then another study back in 2021 showing that African American patients and those with Medicaid were less likely to have an activated patient portal. So again, showing some health inequities that some of our patient population having less access to telehealth, and this is demonstrated by less activation in their online portal. A couple other barriers, particularly for homebound patients. More than 1/3 of homebound patients during this COVID-19 surge had their first video visit at that time. And the majority of them, about 82%, required assistance from a family member or paid caregiver to engage in telemedicine. So that's a little bit about the background, sort of the barriers, the benefits of telehealth. And so let's transition now to if you're actually going to be doing telemedicine for your seniors in an outpatient setting. And so some things you want to think about are listed here in terms of screening questions to assess your patient's access and readiness to participate in a telemedicine visit. So a couple things to consider: do you have vision or hearing impairment, as this might be a challenge trying to connect for a telemedicine visit? What equipment do you have? Do you have a smartphone or a computer? Do you have internet on these devices? Do you know how to access the internet on your smartphone or computer? Do you know how to access your patient portal if your EMR has one? If you're not able to use your smartphone or computer or not able to access your portal, is there someone who can help you? And do you need an interpreter for these visits with your provider? And so it's helpful to have some of this information beforehand if possible, to help um, have a smoother experience during your telemedicine visit. And so a couple of things again to anticipate these challenges to anticipate and ways to mitigate. So for hearing impairment, if appropriate, headphones that are assistive to patients with hearing loss. I have a couple patients who have their hearing aids, ability to connect to their phone or their device so that they can answer calls, for example. Also thinking about the platform that you're using. Does it have closed captioning available and turned on? So if you have Zoom, for example, integrated into your EMR, you're using another approved HIPAA compliant approved platform, knowing if there's closed captioning available. For vision impairment, thinking about an adaptive device or program, so like a magnifying software. And then as the clinician, making sure you're using a plain background that has high contrast. For cognitive impairment, definitely thinking about caregiver assistance or how to simplify the video device program as much as possible. So for example, is there a way to send your patient a quick link that they just have to click to connect to their visit? And then in terms of connectivity and speed, I know it can be quite frustrating if your patient does not have good internet service. And so you might be using landline for audio connection, or you might have to think about converting to a telephone visit if needed. And then in general, a big question that often comes up is, well, who is appropriate for these telemedicine visits, whether they're audio or video platforms? And so in terms of patients who with non-urgent needs, that's definitely something where you can consider coordinating a video visit. You want to make sure they have access to the technology that we've been talking about. Other patients that might be appropriate have non-active chronic medical issues that you might want to sort of do that management of their comorbidities in between in-person visits with telemedicine. Transportation and travel time, waiting room times, if you can reduce those for some of these patients, or if that's important, you might consider telemedicine. So I have, again, some patients where they have advanced dementia and the agitation that they get with the transportation can be quite uncomfortable for the patient and caregivers. So thinking about using telemedicine in between in-person visits. Another limiting factor is a good physical exam, and there are some physical exam components you can do on telemedicine, but if a patient requires a comprehensive physical exam, technically that's probably not the best choice for video or audio visits. Of course, you need to be in the same state where the physician is licensed, and then a person without significant sensory impairments might also be a good candidate for telemedicine. And then I wanted to share logistically some ways to use your interdisciplinary team to help you with the flow. And so, of course, in geriatrics, we value immensely the use of our team and assistance from our team members to help care for our complicated patients. And so this is another way where you can involve your team. So you can have, if you have administrative staff, whether it's administrative assistant or secretary, they can help with a lot of the administrative background. So offering options for visits, review with patients how to make sure they know how to connect to a platform or download the app if necessary. Let patients know there might be delays when connecting, confirming the patient's location, and sending the patient a reminder prior to their visit. Your front desk staff or registrar staff may help with checking in patients, addressing any issues with the insurance, confirming the patient's location and advise them about possible co-payments. If you have other support staff, like nurse practitioners or physician assistants, they can also help conduct urgent visits or transitional care management visits or post-hospital visits using telemedicine. You may have registered nurses or medical clinical associates, like medical assistants, who can help with the pre-visit assessment. So asking patients to collect their vitals prior to connecting, having their medications ready and available for the visit, and maybe doing some in-office screenings. So it might be a depression screening or a fall screening that you can do on the phone. And then be available to help troubleshoot with the patient caregiver any last minute issues. And then a couple other recommendations on how a patient can prepare for a televisit. They should, as always, write down their main concerns, have their medications available to review, have any additional data available for your review. So it might be blood pressure, weight, O2 sat, sugar. Those kinds of data can be very helpful to have prior. Try to be ready a few minutes before. Of course, providers do sometimes run behind, and letting them know that might be something to anticipate. And then making sure, again, the phone or tablet has video capabilities and the most up-to-date version. And then inform them about mobile charges if they're not using their Wi-Fi. And how should a provider prepare for a telemedicine visit? So the locations of the patient and the provider should be considered like a patient exam room. So privacy is a priority. So for providers in particular, making sure you're not in a shared office space where other people can overhear, or in a place where you might get interrupted frequently. For example, those are things important to consider. Cameras should be placed with faces clearly visible. Consider noise canceling headsets and make sure no other noises can be heard, and make sure to test your connection. It's also advisable to turn off your Bluetooth and close any other apps that may compete with your video visit platform. And then you may need a device for the video portion and one for documentation. So if you can have either a split screen or one device for your video visit and one for documenting, that would be ideal. And then you always do want to look professional as much as possible, wearing professional attire, maybe even a lab coat, and making sure that your background looks professional without clutter. And then as much as possible, avoid moving around with your device. And then finally, remember to log out of your session. A couple other reminders during your visit. If you are in the clinic space in an exam room, you might want to consider putting a sign on the door to let your staff know that you're in a video visit. Making sure that you have access to an interpreter or translator if necessary. And this connection might vary depending on the platform you're using and what system you work in, but ideally you would have that connected into the platform you are using with your patient. Again, you want to introduce yourself, confirm the name, the date of birth of the patient, where the patient is, and then you want to confirm who's with your patient. I definitely have had the experience where I asked for everyone who was there, and in the middle of the visit, another person comes in, and you have another individual to consider during the visit. So you always want to ask who's present and who might be joining during the visit. It's always helpful to explain what you're doing. Patients can't really see you fully, so if you're looking at labs or looking at in the computer during the visit, you may want to be more specific and explain that to patients. A couple things about documenting. Depending on where you work, you may already have a template that provides you with some of this information in your EMR. But for compliance issues, it's good to include your patient's location, your location, that they consented to the visit, that the patient was confirmed identification, and then what platform you use to conduct the visit. And then you can proceed as usual to document your history, physical assessment, and plan, as you always do. And then in terms of the physical exam, many of this will be visual, right? So you can record your vitals, but how the patient appears constitutional, their ENT, commenting on their normocephalic, atraumatic, the external ear exam. In terms of the eye exam, you can document extraocular movements, sclera, conjunctiva. For the neck exam, range of motion, or if there's a visible goiter. From a respiratory standpoint, commenting on their respiratory effort, if they're comfortable speaking full sentences, for example. Cardiovascular wise, you can ask the patient to palpate their PMI, but more often I'm also asking to look at their lower extremity edema. The chest exam, one example might be looking for gynecomastia if necessary. For a GI exam, you can ask the patient or family member to do self-palpation to look for tenderness, and you can visually look at the abdomen for size and fullness. You can do a visual exam of the external genitalia, musculoskeletal exam. You may be able to look at some range of motion for certain joints or gait assessment. Skin rashes, ulcers, etc. can sometimes be challenging if you don't have a good connectivity or visual field of the on the video, but that is definitely something that can be helpful on video exam. And then psych and neuro exam as well in terms of their mood, affect, and then also looking for some motor deficits, certain cranial nerves you might be able to do on physical exam. And then another thing I just wanted to point out is as geriatricians or providers caring for older adults, it's also important to think about our 4Ms framework and how can we also do these assessments on telemedicine visits. And there are ways to incorporate the M's and do age-friendly appropriate care during these visits. So for matters most, definitely still possible to set priorities for the visit to make that align with the patient's goals. If appropriate, absolutely can do advanced care planning on audio or video visits. In terms of mind, assessment for cognition and mood is still possible. I find mini cogs to be the easiest and most reasonable to do on video visits. There may be also some components of other exams on the MOCA, for example, that you might be able to complete. For mood, the PHQ-9 can easily be administered. In terms of mobility, assessing for safety, function, and frailty, a couple ideas, a chair stand, 30-second chair stand, or you can do a test for balance with the tandem stance. You can also use the clinical frailty scale, for example. So there are ways to assess for mobility, and of course, doing a good functional assessment is possible in these settings. And then medications, I think video visits are a great way to also have the opportunity sometimes to look into the patient's home and their environment. And one of the key things that often happens on a home visit is taking a look at all the medication bottles that patients have, doing a good med reconciliation and deprescribing an appropriate medication. So this is a great opportunity for patients, especially who don't like to bring their bottles into their visits, to do a good med reconciliation in the setting of their own home. Okay, so in terms of billing, I wanted to go over a couple things. In the 2021 Medicare physician fee final rule did have some big changes. And first, there was changes allowed to allow for time-based billing, which is relevant to even our in-person visits. But also with this update, CMS permanently added 10 codes to the Medicare telehealth list. Those of interest to our geriatrics patients, home visits, the cognitive assessment and care planning services, and then prolonged service codes are applicable to telehealth. Also in 2022, from the Medicare physician rule, they finalized that they will extend through the end of the calendar year 2023 those Medicare telehealth services lists that were added temporarily until the end of the public health emergency. And as I mentioned in the beginning of the talk, in 2023 was the Consolidated Appropriations Act, which allowed coverage of audio only through December of this year. So a couple things to keep in mind. And as we get to the billing, for visits with providers that use a telecommunication system that has both audio and visual, the following codes are available, just as they are for your in-person visits. So the 99201 to 5, the 202 to 5, and the 99212 to 5 are available for all video visits where you have both audio and visual components. And transitional care management visits and annual wellness visits are all eligible for these for billing. For the audio only or telephone only visits, there are 3 separate codes: 99441, 99442, and 99443, which I'll go over later. And again, these are available until further notice up until December. And again, for these video visits, these codes that I mentioned that we use for the outpatient setting are available: advanced care planning, the cognitive impairment care planning codes, transitional care management, annual wellness visit. And then our colleagues in neuropsychology and mental health services do have ability to bill as well, and as well as rehab services, PTOT. This is a reference for you if you are billing based on time, the time for these codes as a reference. And then for audio only codes, again, these were added on temporarily back in 2020. We still have them available until further notice. And then the newly added in 2021, other codes that can be used audio only are advanced care planning codes, face-to-face prolonged services codes, annual wellness visit, and the annual depression screen code and new prolonged care code. And then in terms of billing, this reference gives you the time that you can use, the time spent during each of these level of services. And so for telephone visits here, these are patient-initiated digital evaluation and management service for an established patient for up to 7 days, and that cumulative time is during the 7 days. And so for 99421, this is 5 to 10 minutes. For the next one, it's 11 to 20, and for the next one, 21 to 30 minutes. There is a different code called the virtual check-in code, which is a G2252. I will say most agree that you're better off billing the 99442 code, as this is a higher reimbursement. But this is to use if needed for a brief check-in by a physician or other healthcare professional between 11 and 20 minutes. And this is to provide an established patient not originating from a related E&M service provided within the previous 7 days nor leading to an E&M service or procedure within the next 24 hours or soonest available appointment. And again, pretty infrequently using this code. This is a graph or a table showing the reimbursement rates as of 2024 for these codes. And so you can see in comparison for the facility rates, for the non-facility rates for a 99441, they're ranging from $50 to $120. And then for the with the video, a 99213 ranges 90 up to a 99215, $180. So there is a higher reimbursement for video visits versus audio only, but at least we do have access to these reimbursements at this time. A couple other things to consider: licensure issues. So the interstate licensure telehealth rules and regulations do vary state to state. If your patient has an out-of-state health insurance or wants to receive care outside of your state, make sure that you're meeting the state's guidelines where your patient is receiving care. The Federation of State Medical Boards is tracking executive orders related to licensure, so you can refer to their website for updates. And consider using your legal and billing teams to understand these federal, state, and payer requirements and regulations at your local sites. And then you also might want to consider checking with your malpractice insurance carrier to ensure you're covered to provide telehealth services if appropriate. And I do want to share, there are some additional resources online that you might want to look at for telehealth best practices for older adults. So up here, I did reference in the talk earlier from the American Geriatrics Society, the Geriatrics Evaluation and Management Tools, or GEMS. They do have a nice tip sheet on doing telemedicine or video visits for older adults. Also, West Health created a Center of Excellence for Telehealth and Aging. That is quite a robust website with a lot of resources and references as you are working on doing providing telehealth and telemedicine services to your seniors. There are guides, resources to doing telemedicine in multiple settings, long-term care settings, in PACE, or the Program for All-Inclusive Care of the Elderly, in addition to references for those doing this work in the outpatient setting. And there's also some great materials on thinking about equity and making sure that our telehealth services for our seniors are accessible and equitable. So in conclusion, I do have two questions. The first question is, Miss R is a 73-year-old woman assigned to you as her new primary care provider. She called the practice requesting a refill of her medications, but expressed no interest in scheduling an appointment to see you because she's afraid to come in due to still COVID-19 being in the community. She called the call center and said she's feeling okay. You reviewed her chart and noticed she was last seen in the practice about a year ago. She does have a history of hypertension, diabetes, glaucoma, and back pain. In her social history, she lives with her husband, has 2 children, loves traveling, drinks a glass of wine every night, and was a history teacher. She did have a Prevnar vaccine on her last visit and is due for her Pneumovax. The last mammogram documented in her chart was 2018. She did have a MOCA from 2017. That was 29 out of 30. You could not find a healthcare proxy in her chart, and you noticed her patient portal is active, and she sent a message to her cardiologist a couple of months ago. So what would be the next best step to address Mrs. R's request? A, refill her medications because she is okay and she's an established patient in the practice. B, have your office call her and offer a video telemedicine visit for an annual wellness visit. Call her for a brief check-in and schedule this call as a telemedicine non-face-to-face visit, or D, decline the refill and have her call your office for an appointment. So the correct answer is B, have your office call her to offer a video telemedicine visit. So the other answer is A is not the best because you are the PCP and have not yet met Mrs. R in person. The fact that she hasn't been seen in over a year means she's likely due for an annual wellness visit. Although it's not ideal to not see her in person, she might need a vaccine and other things. You still can respect her concerns and offer to connect initially via video visit. And annual wellness visits are allowed via CMS right now. And so you can definitely go ahead and schedule her for an annual wellness visit. And then a brief check-in might be the next best option if Mrs. R declines the video visit and consents to a telephone. And then ultimately for the last one, declining a refill might result in multiple negative outcomes that would also make it develop. So we do not advise the last option, D. Question number 2, the following are all telemedicine billing codes covered by Medicare except A, the G codes for annual wellness visit 0438 and 0439. B, transitional care management 994956. C, chronic care management 99490. And D, established visit 99214. And the correct answer is C, 99490. Because chronic care management is not a visit type conducted on one telehealth encounter. Thank you so much. If you have questions, feel free to email me, and best of luck. Thank you.